Practicing medicine without insurance is possible. Imagine a private practice where you get to see your best patients every day, providing medical services you truly enjoy, all without the hassle of insurance. My name is Dr. T. Nguyen, and I'm a recovering specialist who was completely burned out from insurance-based medicine. I pivoted into direct care, where patients pay me directly for my medical services and have never looked back. If you're a private practice owner or planning to become one who's looking to be free of the grind of insurance and you're craving simplicity, efficiency, and connection with patients, you are in the right place. This podcast will help you map out your exit plan and uncover the mindset needed to thrive in today's economy. Welcome to the Direct Care Podcast for Specialists. I want to welcome Dr. Demetrio Aguilar from Total Pain Solutions here to the podcast today. Welcome.
Thank you. It's exciting to be here.
I've seen you a lot on LinkedIn, so I really wanted to get to know you because you offer pain solutions, but also it sounds like surgical interventions too. Is that correct?
Yes, that's correct. And really the two are, they're tied to each other because we offer surgical solutions for chronic pain, which I think is I'm a little reluctant to use the word novel because the idea has been around for decades. There just aren't that many of us that are trained to do it. I'm sure as a podiatrist, you're familiar with Lee Dellon, and so he's the one that trained me in peripheral nerve surgery. There's probably, I don't know, 300 or 400 comprehensive peripheral nerve surgeons in the United States, of which maybe a dozen, maybe 24 of us focus almost exclusively on surgically solving pain. And so I happen to be one of them.
Yeah. Do you happen to know Dr. Steve Barrett?
I know the name. I don't know that I've met him.
He was on the podcast as well. He has chosen
Sure.
direct care in his practice, but he's also on the leading edge of nerve surgery, microsurgery,
Sure.
and things. And so it's really wonderful to hear more from doctors, some surgeons who are in this arena, because me personally, pain stuff scares me. It freaks me out. I feel people's pain. And so I don't know how you feel when you interact with patients, but for me, feeling patients' pain is so severe. It makes it hard for me to give complete care because I'm absorbing their stuff. So when things don't go well, I'm there with them. When, things aren't going as planned, it's just been really hard for me. And so actually my favorite kind of patient are those who can't feel, to be honest, because I can be their eyes, for what they can't see. But nonetheless, I really do appreciate the services you provide. I want to learn more about how you started your practice and who are you? What was life like for you before you decided to have a direct care practice?
So those are all great questions. And I mean, oh my goodness, those are in their own way, they're kind of loaded questions, right? So I started out as doing a general surgery internship. I was in the Air Force, and the Air Force wanted me to become a flight surgeon. And they said, hey, listen, would you be interested in getting into the astronaut program? Because we'd really like for somebody to go into the astronaut program as a physician. I said, that sounds awesome. How do I do that? They're like, well, go ahead and start in general surgery, then we'll train you in aerospace medicine. And then after that, we'll go from there. I said, okay, sounds good. And so that's what I did. And I got, I volunteered for a combat assignment, F-16s in Korea. And then that was fun. That was so much fun, flying F-16s and practicing medicine. I mean, they're like, oh, by the way, we'll pay you extra to do that. And I was like, you're going to pay me extra? Where do I sign? Right. But I realized pretty quickly that all the people that I knew that were trying to get into the astronaut program didn't even get the "don't call us, we'll call you" letter from NASA. And I was like, well, if these people who have more letters after their name than they have in their name aren't able to get in, what does it take? So I did a little digging. Didn't take long for me to figure out that, there have been more U.S. Olympic gold medalists than there have been American astronauts, and there have been more U.S. presidents than there have been men on the moon. So I was like, well, that sounds like I should probably choose a different path, something a little bit more achievable. And I realized at that point that I missed the operating room. And so the Air Force was looking to send somebody for training in head and neck surgery, and I volunteered, and and so I got to do, the Air Force sponsored my training at Mount Sinai in head and neck surgery. And during my last deployment to Afghanistan, I was doing a lot of head and neck reconstruction. And then the Air Force said, you know what? We're looking for somebody to further specialize in comprehensive reconstructive and plastic surgery all over the body. And so I volunteered again. And they got my application mixed up with somebody else's, and I got to go to Hopkins. I was very excited about that. And so then, I did my plastic and reconstructive surgery training at Johns Hopkins, and it was there that I met Lee Dellin, who's kind of the godfather of peripheral nerve surgery. And he took me under his wing. He said, I want you to do my fellowship. And so I did. And of course, when I left the Air Force, I figured, peripheral nerve surgery will be maybe 5% of my practice, and the rest of it will be split between head and neck surgery and reconstructive surgery. And I started my practice in July working for one of the hospitals. And by Christmas of that year, 50% of the patients that were coming to see me had pain problems that they wanted me to treat surgically. And so the rest of the practice has grown organically since then. And that was, what year was that? That was in 2014 that I left the Air Force. And now I do almost exclusively peripheral nerve surgery to treat chronic pain. And then, as to direct care, the reason I got in direct care is because I was thinking about opening up my own practice because the hospital was making it harder and harder for me to treat the patients that I wanted to treat. And so one of my colleagues, he's a mentor of mine, he's been in private practice successfully for decades now. I said, how do I do this? Can you teach me how to do this? He said, yeah, I'll teach you how to do it. But what I want you to do first is go to the Free Market Medical Association conference. They'll teach you everything you need to know. I said, okay. Well, I didn't know anything about the Free Market Medical Association, and I went. And I don't know if you've ever had this experience. Maybe some of your listeners have. I got there, and I was in the Air Force for almost 22 years. I felt like I was on a Navy base. Like when somebody like myself goes to a Navy base, all the signs look like they're in English, and everybody sounds like they're speaking English, but I had no idea what anybody was actually saying. I was like, how can this be? I consider myself a reasonably well-educated person, and I don't understand what anybody's saying. And I started to wonder, did I pick the wrong sessions to attend? Until finally, Jake Kempton, who's one of the founders of the Free Market Medical Association, got up and he started talking about the cost of care to an employer, total cost of care to an employer for a total hip replacement at the University of Oklahoma versus the Surgery Center of Oklahoma. And this is in 2017 that I was attending the conference, right? So now you might be familiar with those numbers. I certainly wasn't familiar with those numbers at that time. And I was blown away when he said, yeah, total cost of care. In other words, what the employer pays, whoever the insurance carrier is, so the insurance carrier will then pay everybody else, was $275,000 from the time that the patient identifies the problem until the patient's finally done with all their care. Compare that to the Surgery Center of Oklahoma, who has subcontracts with all the same players and is able to provide care that is as good or better with the same surgeon, get better outcomes. The total cost of care to the employer is $15,000. And I was like, I literally had to stop myself from running out of the room and just vomiting all over the floor. I had such a horrible, visceral reaction to that because right away I realized the implications. I wondered, well, how many of my patients have I done this to? How about all of them? And then, of course, you could argue, well, you didn't know. It's not your fault. You were ignorant. Well, guess what? I'm not ignorant anymore, which means now I'm morally culpable for every single person that I hurt financially moving forward.
Now you know.
Exactly. Now I know. And so now I'm responsible. And that was the genesis of my journey into direct care. Because as Keith Smith likes to put it, I did not want to be an accessory to financial rape any longer. I couldn't fathom continuing to take advantage of my patients that way and really hurting them when these are the people I'm trying to help.
This is such an important point that I don't think we talk enough of on this podcast because we really don't know the financial implications we put patients under when we ourselves don't know the cost of medical care. Right. We may know that, we have a protocol, we go through our checklist, let's say pre-op surgery, for example, everybody gets the EKG, everybody needs to go back to their primary for medical clearance or whatever they need. We just go through our checklist, but we don't know the dollar amount attached to that. We just assume insurance will pay for it. Something as simple as ordering a vitamin D. I don't know if a lot of doctors know this, but that's not covered by Medicare. And I think they bill out $100 or so, a little over $100 for this one test. Sure. That may or may not help us
do the work we need to do. And now you're talking about the cost of medical care per person to the employers could be costing six figures when you can get a way better deal and better care by totally eliminating the middleman. And I
Right.
think that's just something that we really have to repeat over and over again, that what we do as direct care doctors is honest and is transparent. And it does give equal or better care. And I would argue it's better care because the doctor is not burned out. The doctor is working directly for the patient for a limited number of patients because that's our capacity. That is the moral thing to do, is to have a capacity and not treat ourselves as if we are a conveyor belt of medical care.
Right.
And so I'm so grateful that you're able to share that with us, to what turned on the lights for you. So from there, you learned about the heartaches that we all take part in, whether we choose to believe it or not. We are actively doing a disservice when we don't know the price of things, and we choose to make those recommendations anyway. So from there, what did you do?
So at that point, I said, you know what? I can't do this anymore. I need to figure out how I can get into private practice. Well, actually, let me back up. So when I realized the kind of financial impact I was having on the patients, right away I thought, okay, so how can we, number one, take care of patients who don't have much in the way of means in a way that's fair to them and that's fair to everybody else involved. And so I spent a lot of time praying about it, talking to my wife about it, and we came up with what we call the M25 program. And that's a program by which patients who don't have a lot of money can choose to volunteer their time at a local charity by investing their blood, sweat, and tears into their own care so that they don't end up with crushing medical debt. And so I presented this idea to the hospital because I was working for the hospital at the time. I went to the CFO. I had a good relationship with him. He said, "That's great. That's awesome. It checks so many boxes. We can take care of our charitable causes. We can do all this other stuff." I said, "Okay, let's go talk to the CEO." We went to the CEO, and the CEO said, "That is crazy. What are you talking about? Why are you even considering this? We're doing just fine the way we are. Shut up and get out of my office. We've got bigger fish to fry than that." And of course, I walked out of there thinking to myself, well, if you got bigger fish to fry, then I'll just fry the fish myself. And so I said, okay, how can I do this and try to thread that needle and navigate, all these concerns regarding insurance? How do I talk to patients about it, so forth and so on? Well, I discovered something interesting, that the only way that I could reasonably offer the M25 program or some other type of charitable program like that to my patients was to get out of the insurance game. Because if I said to a patient, let's say I had a contract with, we're not going to name any names here, so we'll say United Wealth Scare, okay? I have a contract with United Wealth Scare, and my patient happens to have that insurance. And I say to the patient, you know what? I want you to volunteer some time at the Least of My Brethren, which is a charity that helps homeless people get off the streets into their own homes and helps them get jobs and retrain and so forth and so on. They do awesome work. If I offered the patient, go ahead and volunteer some time with them, guess what I just done? I just violated my contract with United Wealth Scare, which means they're going to claw back a whole bunch of stuff. I might be subjected to fines. And then, of course, if I offered that to a Medicare beneficiary and I had a contract with Medicare, well, not only did I just violate my contract, I just broke the law. I don't generally like wearing stripes, so I figured, that's probably not a good thing to do. And so the irony is, in order for me to help the people that are most vulnerable, I had to get out of the insurance game, which everybody assumes is the best way to help people who are vulnerable. And,
Mhm.
I discovered along the way that there was a lot of brainwashing that I had to undo and really rethink my paradigms in order to get to where I am today as a peripheral nerve surgeon doing direct care.
That's crazy. You just gave us a load of information, because you're basically saying what we were all believed to be true, is that the best way to give best care to patients is to take insurance. But we're sitting here in defiance and saying, actually, no, that is not the best way to give medical care. The best way is to walk away from contracts that are so restrictive and punitive. On top of that, we want to do good, but we'll get punished for doing more good than the contract allows. We're able to do better with direct care.
That's absolutely right. That's absolutely correct, because direct care does, and of course you know this just as well as I do, direct care puts the patient back in the driver's seat, right? It gives the patient, it respects the patient's dignity, it restores the patient's autonomy, and most importantly, it restores the doctor-patient relationship. And so, if I did things the way I used to do them, and I said, you need surgery, well, who has to give prior authorization? Well, the insurance company does. In our model now, who has to give prior authorization for the surgery? The patient. The
Mhm.
person who's going to deal with the consequences of the surgery is the one that makes the decision about the surgery, not some person in an ivory tower 1,000 miles away who's never met the patient, doesn't really care about the patient, and doesn't know anything about the patient.
So how did you get to this realization? I mean, from start to finish, you went to a conference, you were bewildered, and then
Oh,
you
yes.
drank the juice, and then you're like, let's do this. You found some help, somebody who is experienced, and then you decided, I'm going to do this. What was the trajectory of that process? How long did it take you from going from that idea to now I have my practice and I'm just going to do it my way?
Sure. So I'd love to tell you that it was quick and easy. I just turned a key, I flipped a switch, and boom, there it was. Everything was perfect. That would be a lie. Okay. And so for anybody out there that's thinking about this, it's thinking, oh, you know what? There are turnkey solutions. There might be, but I would highly recommend that you don't do it the way I learned every single lesson along the way, the hard way. And so I'd like to share those lessons so that your listeners don't have to do it the hard way, right? So
Mhm.
the first thing I did was I said, okay, I'm going to come up with a practice model. I'm going to hire this many people in these roles. I'm going to open up the doors. I got a loan from the bank. I opened up the practice, and what I discovered, and you'll be horrified by this, as a direct care surgeon, I started out with 9 full-time employees and 4 1099 subcontractors. Okay, and you're thinking to yourself, holy crap, you're a direct care surgeon. What are you doing with all of those people, right? For one surgeon. Well,
Mhm.
that's nothing compared to one of my colleagues here in Omaha who's an OBGYN who runs a conventional insurance practice. And he has 11 coders and billers working in his office, 4 of whom are dedicated just to Medicare claims. So I figured, oh, well, I'm way ahead of him. Look at me, Dr. Innovative, right?
More is better.
Exactly. You know, and I found out really quickly that overhead was killing me. Not only that, not only did I hire too many people, I hired some of the wrong people, in which case I was leaving 6 and 7 figures on the table in terms of, because what we decided to do is, okay, to make this more palatable to patients, we're going to say to them, listen, you pay us cash, but as a courtesy, we'll submit the bill to your insurance company on your behalf, and then you're responsible for chasing it down. Well, what I discovered was that when you offer to do any of that stuff on behalf of the patient expects you to do all the rest of it too. And there's no
Mhm.
chasing down that's done by the patient, which
Mhm.
means that you're in the same pickle you were in originally, except now you have
A different
patients.
jar.
Exactly. It's a different jar. And the patients are asking, well, where's my money? Because I
Mhm.
already gave you money. Why aren't you chasing after the money from the insurance company? And so it took me a while to figure out, you know what, we need to get out of the game completely. You can't sit on the fence. When you sit on the fence, it hurts your crotch. It's that simple, okay? It's really that
Men and women.
simple. Exactly, men and women. And so, you got to decide, which side of this fence am I going to be on? Am I all in or am I all out? And when we finally decided to go, all in or all out, if you will, with respect to insurance, which was about 3 years ago, where we finally cut the last cord, we cut down to 3 full-time employees, myself included, and 1 1099 subcontractor. And so we reduced our payroll significantly, which gave us the flexibility to be able to do all kinds of other stuff. And now, this past September was the busiest month in terms of surgical volume that we've had since my practice opened in 2017. And October was almost as busy, what will be almost as busy. The schedule's mostly full. And then November, if it weren't for Thanksgiving, November would actually be the busiest month of the entire practice in our history.
Wow, that's a huge change. Because I'm thinking you got to cover their health insurance, you've got to pay for the stress you have to endure to juggle the schedule.
Oh, sure.
Yeah, and being able to reduce that down. I mean, I know how good it feels to buy back your time. I mean, and your sanity and the financial risks involved in all of that. So I wanted to kind of just pivot a little bit because I want to understand how patients find you and then choose to pay out of pocket at this point since you don't contract with insurance.
Sure. So one of the things, this is, if there's any one thing that I would want to share with your listeners who are thinking about making the switch, it's this. And you probably had a similar experience. Just about everybody else I've spoken to has said the same thing. When you decide you're gonna step outside the system and move into direct care, everybody that used to refer patients to you thinks you're dead. Like they treat you as though you don't exist anymore. None of the referrals show up any longer because they don't want to deal with the questions that are associated with having to deal with the practice because they don't know how to answer those questions. They're not familiar with those things. And so those referrals go away.
Mm-hmm.
And that was something that was really painful for us at the beginning. Thankfully, we had cut back on our overhead initially, not as much as we have now, but we had cut back on it enough that we could survive on a smaller portion of the revenue than we had originally dealt with initially. Anyway, what we started doing, I started talking to other physicians. I would go to their office, I'd bring them lunch, I would do all the usual stuff a sales guy typically does, right? Because when you're in direct care, you have to be able to talk about your practice. You have to be able to tell people this is what we do, this is why we do it. This is why you should come see us, why you should send patients to us. Well, mostly it fell on deaf ears.
Mm-hmm.
And what I discovered was that direct to consumer marketing was the key. In other words, I needed to know who my audience was, and in this case, it was the patients, and help the patients understand why this was better for them. Because if we're going to cut out the middleman from a financial standpoint, then let's just cut out the middleman from a communication standpoint as well. Right.
Mm-hmm.
And so we started doing direct to consumer marketing primarily through Facebook and through YouTube. At first, we didn't pay any money for any of it. We would just put posts on Facebook at least 2 or 3 times a week, sometimes multiple times a day. And then YouTube, we started collecting video testimonials. And here's another thing about video testimonials. So at first, when we started doing this, I thought, well, they got to have the perfect story for me to share it. And what we discovered was that if the patient's not pissed off, just ask the question, will you share your story? Because, if a patient is willing to say yes, they're not going to badmouth you in that story, right? And if you have somebody that knows how to edit out all the ums and the ums and the, and stuff that's awkward, and you can, pare it down to the core story, then that can be really compelling. So on our YouTube channel, we've got over 400 videos now, most of which are video testimonials, patients talking about their experiences. And so then again, what do? We offer the patients our expertise and our time, and then we leave it up to the patient to decide whether or not their problem is worth the same thing. I think the challenge, there's a paradigm shift that needs to happen when we switch into direct care. Most physicians aren't accustomed to the idea of judging the value of their time and their expertise. And so as a result, they're not comfortable having these conversations with patients that have to do with money. And so what we did is we turned that around. And I said, yeah, and I still say this to patients. I don't have to say it nearly as often now because they get it. But generally speaking, I'll say to the patient, what is your problem worth? Because I have no idea what your problem is worth to you, how it affects you, what the impact of that problem is on you. I don't know what that impact is.
Mm-hmm.
And I wouldn't presume to tell you what your problem is worth. But your insurance company wants to tell you what your problem is worth. The insurance company wants to tell you what you're worth. I'm not going to try to step into that because I'm not in a position to be able to tell you that. Only you know that. But what I can tell you is what my time and my expertise are worth. And here it is. And if that meets with what your problem is worth, then let's move forward together. And if it doesn't, well, then let's shake hands and go our separate ways, no hard feelings. And that kind of a frank, upfront, transparent discussion, I think, is really refreshing for some patients. Some of them, it's kind of shocking, but when they get over the initial shock, they realize, you know what? I've treated them with dignity. I've treated them with respect. I treat them as the intelligent human beings they are. I don't say to them, oh, it's too complicated for you to understand. I say, no, this is simple enough for you to understand. Here's how it works. You decide. You
Mm-hmm.
decide what your time, your money, and your problem are worth, and then let us know. And we put the patient back in the driver's seat, just where they should have been the whole time.
That's a really great way to frame the conversation to empower the person to choose rather than just saying, well, your insurance thinks this is fine, we'll do that instead. Especially for pain, insurance pays for the cheap stuff, right? They'll pay
Right.
for the steroid injections, they'll pay for an amputation. Everything else in between, balls to the walls, it's not going to be covered no matter what your premium is. So I really like the way that you frame that. And I wanted to ask you, because it's not often we get a direct care surgeon in-house, because there's this perception that surgery should be covered by insurance. And I get that. And I myself have reduced my surgery significantly because it's just a lot of processes. When I schedule a patient for surgery, they are either going to the facility or hospital, and then I have to deal with that entity who has to then deal with what the patient's responsibility is and what their estimated costs are. So I'm wondering what that looks like for you and what you do.
Sure. So that's a great question. And so there's the way it looks today and the way that we're hoping it's going to look 12 or 18 months from now. So I'll start with where we are today. Right now, there are a few facilities that we work with where those are two separate conversations. We have the conversation with the patient about the cost here in our practice, and we give it to them in writing in advance. We say, this is exactly how much it's going to cost. No questions asked, no hidden fees, no surprise bills later on. And if I end up having to do more surgery than this, well, then that's not your responsibility. That's mine. As a surgeon, I should be able to plan out for these elective procedures exactly what it is I'm going to do. And if I end up having to do more, well, that's poor planning on my part. The patient shouldn't have to suffer for that. And then we have the patient have a discussion with the financial people at the surgery center about what those costs are going to be. Now, we've done this enough times with the two surgery centers we work with that they've gotten accustomed to having those conversations. And so it can go relatively smoothly, certainly compared to the way it used to be. What we would like to do, though, is a model similar to the Surgery Center of Oklahoma, where you have one bundled price and the patient doesn't have to worry about, well, wait a minute, you mean I got to pay a facility fee, I got to pay an anesthesia fee, I got to pay a professional fee, and that can be really confusing for patients. You don't go to McDonald's and say, okay, I want a Big Mac, and they say, okay, well, you got to pay this person for the bun, you got to pay that person for the meat, and you got to pay this person for wrapping all of it together.
Mm-hmm.
You just want to pay one price. And so that's our goal, is to eventually get there. And so we're working on a mechanism to do exactly that, to bundle it all together here in the Omaha area in a way that's simple, predictable, transparent, affordable, and easy for the patients to understand and wrap their heads around. And we're hopeful that we'll be able to work out those details here in the next year to year and a half. Theoretically, it's possible that we might even have a mechanism in place by March of 26, although I think that's probably a little bit ambitious. But regardless, it's being done in other parts of the country. We see it happening in Wisconsin at places like Renova Health. We see it being done at the Surgery Center of Oklahoma. We see it being done at the Texas Free Market Surgery Center, obviously in Texas, right? We see it being done at Veritas Surgery in Idaho. I mean, it's happening all over the country across multiple time zones. And the reality is, a lot of people have this idea that, oh, well, direct care, this new idea. That's a lie. That's the biggest distortion of the truth that you could possibly have in medicine. Direct care is the way medicine was practiced successfully for thousands of years all around the world until the mid-20th century here in the United States, when somebody decided, hey, let's introduce this health insurance idea, which effectively is an experiment. And now we can see largely a failed experiment. And so what are we trying to do in the Free Market Medical Association? We're trying to recapture what we know is tried and true, what has worked for centuries, around millennia, all around the world, and is working again in certain parts of the United States. We're trying to recapture that and then add some modern flourishes and refinements, and then just say, look, here it is. Here's the future of medicine.
That is really great. I used to say the same thing. It's what medicine is supposed to be, between the patient and the doctor. That's all it really is. Everything else is just extra paying for people to have a job, basically.
Right. Exactly.
And, for surgeons like myself, I had to find alternative ways to provide care. And so what I get to do is perform procedures in my office. Now, I know some states have restrictions around that. So if a patient can be under local anesthesia, then that's a viable alternative, although you need to develop the skills and the setup to make that happen. I wonder for you, are there procedures that you now bring in-house, or is everything under anesthesia? What does that look like for you?
That's a great question. So, I do a lot of carpal tunnel surgery. We do that in the office under local anesthesia with ultrasound guidance. Patients are back to work the very next day without any activity restrictions, which
Same.
is a significant improvement compared to the way I used to do it when we did a mini open procedure and it was 3 to 6 weeks before those patients were back to work. I mean, a lot of our patients drive themselves home after their carpal tunnel surgery because there's no sedation. It's strictly local anesthesia. We do trigger fingers the same way. 50% of my practice is patients who have post-herpetic neuralgia, chronic pain after shingles. And for those patients that come in that have it isolated to certain parts of their face, a lot of those procedures we could do in the office under local anesthesia also, and they feel better walking out the door than they did when they came in. And so I'm a really big advocate of doing procedures under local anesthesia when it's appropriate to do so, because number one, it's safer for the patient. Number two, it's more convenient for the patient. Number three, it's more convenient for us because we have fewer schedules that we need to coordinate. And then it's more affordable for the patient. The patient can ask questions in the middle of the procedure if they want to. Doc, what are you doing now? Or we actually have a monitor on the wall so that patients can ask questions about what I'm looking at, and they can point to the wall and say, what is that over there? And what's this over here, while we're doing the procedure. And so it's an opportunity for greater education along the way as well.
I want to shadow you someday. Is that okay?
You're welcome to come out to Nebraska.
I want
We'd
to be
love
like
to
you
see
when
you
I
here.
grow up. We have really advanced so much as far as pain relief for patients, doing a lot more under our local with imaging. And I just feel like it's such a sexy thing to do as least as possible to get the maximum benefit. Whereas I feel like in the olden days, where we open things up and we put a bunch of screws and plates in, that is going on the wayside for some things, not everything.
Sure.
And so
Sure.
I'm really excited about this, the field of being able to perform surgeries minimally invasively in the office for all the reasons you listed. It's good for me. It's good for the patients.
For sure.
It's good for the ecosystem of healthcare. We're not wasting money. We're not wasting time or dollars.
Exactly. And we're not putting patients at undue risk. I mean, when I first got introduced to this idea was, when I was a head and neck surgeon, and I would fix a lot of broken noses. And so a lot of people take those patients to the operating room. They put them to sleep and they straighten out their nose. And it's not like you see on TV where, you got some football coach who goes, okay, look over that way, crack, It's not like that. It's a very gentle procedure if you do it properly. And what I discovered was that if you adequately numb that person up, and then you give the local anesthetic time to work, you could effectively chop somebody's nose off and they wouldn't know it other than the fact that they could see that it's not there anymore, right? So it's possible to make those patients really, really comfortable. And I discovered, what? If I restructure my day so that I can accommodate those things, so I'll see one patient, numb that patient up, I'll go and see another patient while I'm waiting for that patient to get ready. Then we're utilizing our time more effectively. And then I started doing the same thing for carpal tunnel surgery. We started doing the same thing for various other procedures on the face. I mean, there are certain types of sinus procedures you can do in the office under local anesthesia, which is like 15 years ago, that would have been unheard of. People would have said that was malpractice. And now in many parts of the country, that's the norm. Somebody needs a balloon sinuplasty because they got chronic sinusitis in their maxillary sinus. You can do that endoscopically with a balloon and wide awake, and the patient will tell you the moment that it gets better. I remember the first time I did it, and the patient was like, Doc, what did you just do? I feel amazing all of a sudden. I was like, well, I said, good. I hadn't expected that, and the patient was like, that's awesome. Can you do that on the other side? I'm like, well, that's the plan. Let's switch over to the other side and do that for you.
I love telling patients when they feel good. I'm like, oh, I didn't expect that.
Yeah, exactly. I tell them, oh, well, I'm glad because that's what the YouTube video said you were going to say.
Right. We got it right this time. Yes.
Exactly. Of course, then I tell them, well, most of those YouTube videos on this procedure were done by me anyway. So at least I'm listening to myself, right?
That's so wonderful. Oh my gosh. I know there's so much more to share about your type of practice, about
Sure.
surgery, about the business aspect. And I don't want to take up any more of your time. So I wanted to ask you, what is the one thing you would recommend the doctor who's on the fence about direct care?
The biggest recommendation I would have, it'd be one of two things. Either one, go to the next Free Market Medical Association conference. Okay. I don't know if it's going to be in Oklahoma City. they're toying with the idea of maybe going to Nashville for this next one because we've run out of space. Every year there's more and more people attending the conference. And I suspect I'll be speaking at the conference again. That'll be my like third or fourth year in a row speaking at the conference. So, and I usually talk about exactly what we've talked about. How do you start and run a successful direct surgical care practice? That's one of my passions, and one of my big long-term goals is to raise up the next generation of direct care surgeons. So that would be my highest recommendation. If you're not sure whether or not you could do it, or whether or not you want to invest the time and energy and money into going to that conference, then find the local chapter of the Free Market Medical Association and attend their meetings. Most of the time, most of the chapters don't charge anything. You just show up and meet people and learn about direct care. Because what you're going to discover when you go to these meetings is that there's all kinds of people at various stages of this transition from conventional insurance-based medicine to direct care medicine, and they're at different phases of that journey. And there's lots to be learned from each of those people about where they've been and where they're going. And even for somebody like myself, I've been doing direct care now in some form for the last 8 years. I learned stuff from other people who are on this journey because they'll say something. I'm like, oh, that's a really good idea. Yeah, I'm going to incorporate that into what I do. And then finally, the last thing I would say is don't be afraid. We've all been taught to be afraid of the risk associated with this, with the unknown. But I tell this to surgeons all the time. If you're an MD, I'm not familiar with the statistics for other degrees, but if you're an MD, when I applied to medical school, there were 45,000 applicants nationwide for 15,000 spots. That meant 2/3 of the people that were applying failed. Did that stop those people from applying? No. They weren't afraid of that kind of failure rate. I went to Boston University, and the last day of orientation, they gave us a whole bunch of statistics. And they said one of the things that stood out in my mind, there were 15,000 applicants for 150 spots. That means 99 out of 100 people who applied failed to get in. They just got me mixed up with somebody else and I got in. So I was very thankful for that, right? When I applied for plastic surgery, there were 2,000 applicants for 2 spots. Okay, those are really daunting statistics, and those are daunting odds. The likelihood of failure there is greater than 99%, but the likelihood of failure when you go into direct care is significantly smaller than that. As a matter of fact, I struggle to think of somebody that I know that went into direct care that wasn't able to make it work. It is possible. Is it scary? Yeah, it is scary. But you overcame great fear to get to where you are today. Why turn your back on that legacy and give into fear now?
I completely agree. I can only think of maybe a few people who I wouldn't necessarily say failed direct care. They just had to pivot before they became financially stable to make the decision. And so I'm with you. Once people go direct care, they really don't go back.
Right.
So,
and the same thing is true for patients. So, in our practice, for instance, my, the 2 staff members that I have, my team members, I don't refer to them as staff members. And that's another thing, you got to change your mindset also about the people you work with. But that's another discussion for another day. I told them, I said, if we're gonna talk the talk, we got to walk the walk. And so I didn't offer them insurance. What we do instead is I have each of them plugged in with a direct primary care subscription. I pay for that. And I also pay for a subscription to a health share. And they understood this stuff conceptually, but until they started to use it, they didn't really understand. And now they're like, Doc, we could never go back. I'm like, see, I told you. And they're like, this is way better care than we ever got the old fashioned way. And they're like what we like to call true believers now. They're some of the greatest evangelists there are. Once you get somebody into the direct care system, they're not going to want to go back.
yeah, you're completely right about that. Some people just feel like what they have with their insurance option is good enough, and they've accepted that to be normal.
Yeah,
They
it's a
think
kind
that
of Stockholm syndrome.
yeah, it's like it's normal that I can't be seen for 8 months, although my foot's falling off. Like, come on. I guess
Exactly.
there comes a point where, hey, that's not right.
Yeah. Well, and then on the financial side, like if we think about, my practice, I mentioned I do carpal tunnel surgery. So the average cost for a carpal tunnel surgery, unilateral under general anesthesia here in the Omaha area is about $20,000. Okay. Now, let's say the average deductible for a family of 4 in the United States is about, I think it's $8,500 now. But let's say you have good insurance, right? And your deductible is only $5,000. So out of that $20,000, right away, you're going to pay $5,000. This is for one hand, right? You're going to pay $5,000 right away. And then you got the 80-20 split, right? So you're going to be responsible for 20%. The insurance company's going to be responsible for 80% up to a certain amount. So what's 20% of the remaining 15,000? I'll do the math for you. $3,000. So that's $8,000 right there that you're going to pay out of pocket for the privilege of using your insurance, right? Or you can come see me here in Omaha. I can do both hands under local anesthesia. You could drive yourself home. We don't use insurance, and it'll cost you less than half that much for us to do both hands, and you're back at work the very next day.
What a great pitch. I love that. We know so many people who need that. So
Yes.
That's a great one. Awesome. Well, thank you so much for your wisdom today and for sharing is it 7 years, 8 years long of experience now?
8 years now.
I've been in practice. I've owned my practice for 7 years. So I'm just cruising alongside you, except I was in direct care more like 3 years. It took a little while to get there.
I know that feeling.
Well, thank you so much. How can people get in contact with you?
The easiest way to get in contact with me is to email us at totalpainsolutions.net. You can also check out our YouTube channel. It's Total Pain Solutions. You can also find me on LinkedIn. Obviously, I'm pretty active on LinkedIn. I know you are because I see your posts. We're also on Facebook, or you can just swing by. We're right here in Omaha. Just Google us and you'll find our practice. We've got some videos showing, we got this drone that hovers over and shows people, okay, this is what it looks like. This is how you find us.
That's pretty cool.
Kind of fun. Doing that was a lot of fun. But yeah, I mean, we're happy to help. If you're a doctor out there that's thinking about doing this, you want to learn more about it, come check us out. Oh, one last thing. I also have a podcast that talks about direct care. I'd love to have you as a guest, as a matter of fact. And the podcast is called The Direct Care Movement. And you can find it on, I know we're on YouTube. I'm pretty sure you can find it on Spotify and Apple Podcasts as well.
Yeah, I'll check it out. And I'll put all the information down in the show notes so that people can get more resources on how to do this, because we're not turning back.
No, for sure.
We're in it for real.
For sure.
Okay,
yeah, we're excited.
Cool. Thanks so much.
Thank you.
One last thing. If you took anything from this episode, whether it's a small dose of inspiration or even an aha moment, could you please share it with a friend or post it on LinkedIn? The direct care community depends on doctors like you because no one is coming to save us. So it's up to each and every one of us to keep the conversation going to a point where direct care becomes a normalized path for private practice and not some secret that we have to mine for. Thank you if you've already done so, or if you've given this podcast a review. It really does mean a lot to me. Sending you peace and possibilities. I'll catch you next week. Take care.